So thank you very much to the chair and the speakers from the previous session, and we're going to move on with our lunchtime session now. I'm Adam Hastings, I'm chairing this session. And given that it's called a lunchtime session, I think that means that you're all entitled to ensure that you're having lunch while we're listening to Professor John Yee, who's going to talk to us about the theory and the practical applications of Brainstem auditory evoked potential monitoring. John comes to us from the Princess Alexandria Hospital in Brisbane, which hopefully is having some slightly nicer and warmer weather than we're having down here in Sydney at the moment. John's a Brisbane local. He was educated and trained in Brisbane, and he's now the Director of Perioperative Neuromonitoring at the Princess Alexandria Hospital, and works for the University of Queensland as a clinical lecturer in the School of Medicine. And if that doesn't keep John busy enough, he spends his spare times engaging in high-level, wonderful performances in classical music. I'm led to believe that he's a cellist and a pianist and a tenor vocalist, and that he performs regularly. And John, I don't know how you managed to squeeze it all into your day, but thank you very much for joining us with this wonderful lecture.
Good afternoon, everybody. My name is John Ye. I'm from the Princess Alexandra Hospital and the University of Queensland in Brisbane, Australia. This afternoon, I'll be talking about the principle and practice of the Brainstem auditory evoked potential. And I'd like to thank the organizer for inviting me to do this talk, and also congratulate the organizer for this great event happening in Asian Pacific region. I have nothing to disclose. So in this talk, I will start with a bit of an introduction on auditory evoked potentials and a bit of a history. And I'll also be discussing the auditory pathway, then onto the Brainstem auditory evoked potential, BAEP, and then finish by the application of the intraoperative neuromonitoring. So auditory evoked potential, also known as AEPs, are changes of the electrical activity of the brain, EEG, which is produced by the auditory stimuli. Evoked potentials are produced by the change of electrical potential across neural membranes in the auditory system. AEPs are much smaller than EEG and are thus not visible on the raw EEG. And the most common method is to isolate to generate the AEP from the background EEG with the averaging EEG response to multiple identical stimuli. The auditory evoked potential will remain constant for all stimuli because it is time-locked, while the background noise will vary and thus be reduced by averaging. I must reiterate that AEP is not a hearing test. So the auditory evoked potential can be divided into three categories. That is short latency responses, which is less than 15 milliseconds, and then mid latency response, which is happening between 15 and 50 milliseconds, and the long latency response, which is greater than 50 milliseconds. And the diagram on the top right from Michelini demonstrates the relation between the waveform and the latency. So in general, short latency response is almost a subcortical response. It is small in amplitude. Some of the examples from short latency responses are electrocochleogram, ECOG, cochlear microphonic, and Brainstem auditory evoked potential. Whereas MLR and LLR, they are cortical response. They are relatively larger. And so for the mid latency response, typically it's like steady state evoked potential. And in long latency response, examples are like P300 response, mismatch negativity, and M400 response. It is worthy to note that MLR and LLR are highly variable, and under GA, they are not they are quite variable, so they are not quite good to be used in intraoperative neuromonitoring. So it really started back in 1930 when Weaver and Bray first recorded some cochlear potential, later known as cochlear microphonic in animal. And towards late 30s, Davis and colleague recorded the electrical potential emanating from the surface of scalp in response to an auditory stimuli. And then towards the 60s, we see Geisler and the colleagues reported the recording of the auditory middle latency response. And then we begin to see the use of cochlear potential in clinical settings. Then in 1967, we saw Dr. Sohmer and Famiser from Israel who reported the first recording of ABR via the ECOG, showing series of peaks occurring within 60 milliseconds, which was described non-specifically. In 1970, Jewett described the ABR in animal with neural response to auditory stimuli recorded from brainstem pathway of cats. And later that year, that he and the colleagues described the human auditory evoked potential, possibly brainstem components detected on the scalp. So on the left, A is the sound stimulus, whereas B down to E, the subject with the response. Figure on the right, they are recordings per subject with different filter setting, as well as different recording sites. In 1971, same group of authors conducted systematic study in human and suggested the activity represents nuclei and tract of the brainstem. On the left, the authors assigned a series of Roman numerals, namely 1 to 7 to each peaks. The middle figure, they demonstrates the effect of repetition rates of the stimulus. And it is worthwhile to note the loss of definition of the wave components as the stimulus rate increases. The height of wave 1 decreases with increasing rates, while the wave 5, the latency increases. They've also demonstrated a different sweep speeds and the filter settings affect the waveform on the right. During the mid-70s, we saw the start of using ABR in hearing threshold estimation for both infants and adults. It is also around this time people began to look into the correlation between ABR and the different aspects of pathology. So Starr and Arcourt in 1975 described ABR in patients with CNS pathology. On the left, that is the subject with normal ABR. In the middle, they've demonstrated the tumor that destroyed the brainstem with the marked decrease of amplitude for wave 4 and 5 compared to the normal. And they also demonstrated the ABR in patients with multiple sclerosis and the ABR before and after cardiac arrest on the right. And then we saw the reporting of abnormal ABR in acoustic tumor detection. And in early 80s, we saw the first reporting of intraoperative neuromonitoring of brainstem auditory evoked potential. And also the systematic application of ABR in ICU monitoring. And we also saw the first report of auditory nerve compound action potential, ANCAP, recorded from Moller and Janetta. It has also been used to determine the brain death in around that time. So the brainstem auditory evoked potentials, BAEP, they are known by other names as well, such as auditory brainstem response ABR, brainstem auditory evoked response BAER, or brainstem evoked response BACR. Despite they are different, they are the same. BAEPs are short latency evoked response that reflect depolarization of several structures within the auditory pathways. Each waves represent electrical values from the cochlea in response to sound stimuli of the auditory receptors to the upper palms. So wave 1 is believed to arise from the distal portion of the cochlear nerve, and the latency is generally around 1.62 milliseconds. Wave 2 was thought to arise from the cochlear nuclei, but some other reports suggest that it's arise from the proximal portion of the cochlear nerve. The latency is generally around 2.8 milliseconds. Wave 3 is considered to arise from the lower and mid-palm junctions at the level of superior olivary complex, and the latency for wave 3 is generally around 3.75 milliseconds. Waves 4 and 5 are thought to arise in the mid and upper palms, lower midbrain, respectively. And the latency is about 4.89 and 5.62 milliseconds, respectively. And then wave 6 and 7 are considered to arise at the level of the medial genicular body and auditory radiations, respectively. And out of these waves, waves 4 and 6 and 7 are highly variable. And because of this, those waves are not very useful in terms of neuromonitoring. When analyzing results, apart from using the latency from each peak, we also need to consider the interpeak latencies, as they are generally accepted as a measure of central neural conduction time. These can be influenced by the myelination of the nerve fiber. So, for example, in the age less than 2 years, there will be a huge difference between infants and adults. We also need to consider the difference between each side from the left or right. So from the structure of each peak, we can assume that 1 and 3 interpeak interval between 1 and 3 are peripheral, and 3 and 5 can be considered as central. So in order to analyze the data, we need to have the clinical norm and the normative data to assist our data analysis. Here's an example of normative data with the level at 80 dB NHL. Now, due to factors such as age, myelination process, and etc., it is recommended that each lab should have its own normative data for specific age group, which can be used as a baseline data. So at the present, the ABR can be used to assess the integrity of the auditory pathway in both peripheral and brainstem pathway. And it provides a differential diagnosis of retrocochleation prior to MRI with contrast. It is also useful in neurological applications such as determine the extent of brain damage in head injuries patients, and also detection of vascular lesion in the brainstem. It has also been used widely in estimation of hearing thresholds in infants, young children, difficult to test individual, and pseudo-hyperacusis. We have briefly discussed the auditory pathway at neural level. However, it is also very important to understand how the peripheral auditory pathway works, as we utilize this to deliver the auditory stimulus. The picture on the bottom right might tell you why. The peripheral auditory system involves conductive mechanism that is in both external and middle ear, and to inner ear, and then to neural pathway to cortex. In general, sound waves initially reach the pinna, and with its architectural design, sound wave may become aggregated in the external auditory canal. The sounds then travel further towards middle ear. When the sound reached the eardrum or tympanic membrane, it passed the sound wave to the bony structure in the middle ear, known as ossicles, which comprised malleus, incus, and stapes. They are to mechanically convert the vibration of the tympanic membrane into amplified pressure into the fluid in the middle inner ear. So here is an illustration of the relation between the tympanic membrane and the ossicular chain in the middle ear. And due to impedance mismatch in the middle ear system, only 1% of energy are being transferred from tympanic membrane into fluids into the inner ear. And the physical property of ossicles to the tympanic membrane has the level arm factor of 1.3. Since the area of the eardrum is about 17 times larger than that of the oval window, the sound pressure is concentrated and leading to the pressure gain of at least 25 times. The inner ear is a fluid-filled space surrounded for the most part by immovable and incompressible bone. The exceptions to these immovable boundaries include the connection to the middle ear, both oval and round windows, and relatively long and narrow fluid fields and connection to the semicircular canal, brain, and body fluid spaces. Inside the cochlea, this is where the physical sounds are being converted and coded into a neural signal. The cochlea is a spiral channel known as the modiolus through the bone. And in the middle of it is a large bony projection, which looks something like a wood screw. Resting inside the cochlea is a cochlear duct or scala media, in which the event related to sound transduction occurs. A stiff structural element within the cochlea of the inner ear, which separates two liquid-filled tubes that run along the coil of the cochlea, is basilar membrane. This is where the action took place. In a normal ear, the movement of the basilar membrane is nonlinear. For lower sounds, level and up to about 60 dB above hearing threshold is called cochlear amplifier, which provides a mechanical amplification of basilar membrane movements in the narrow segments of the basilar membrane near the apical ends of the passive traveling wave envelope. In response to stimulation, a fluid pressure difference across the basilar membrane resulting from an inward stapes movement causes it to move up. The upward basilar membrane movement causes rotation of the organ of quality towards the modiolus and the shear of the reticular lamina relative to the tectorial membrane that deflects outer hair cells, stereocilia, in the excitatory direction. And this deflection opens mechanoelectrode transduction channels, which increases the receptor current driven into the outer hair cell, causing depolarization of the outer hair cell. The outer hair cell depolarization then causes conformational change in Brainstem molecules that induce a reduction in outer hair cell length. And the outer hair cell contraction pulls the basilar membrane upwards towards the reticular lamina, and which amplifies the basilar membrane motion when the pull on the basilar membrane is in the correct phase. On the other hand, outward stapes movement cause downwards basilar membrane movement and results in outer hair cell hyperpolarization, expansion of the outer hair cell, and a further downwards push on the basilar membrane. In general, high-frequency sound produces maximum basilar membrane movement at the base of the cochlea, which is near the stapes, whereas low-frequency sounds also activate the apical part of the basilar membrane. Once the sound has been processed in cochlea, information about timing, frequency, and intensity of sounds is then transmitted by highly efficient ribbon synapses to the spiral ganglion neuron for further process, and then the impulse travel towards the brain via the auditory nerve. Cochlear microphonic is generally regarded as a response from the cochlea that mimics the input stimulus. It is also a variant of ABR where the recording electrode is placed as close as practical to the cochlea. It is a growth potential generated by the outer hair cell in cochlea known as receptor potential. So the cochlear microphonic can be recorded via the electrocochleography ECOG, which showed on the top right figure. The ECOG comprised the three components, not only the compound action potential CAP from this portion of the auditory nerve, but it will also record the cochlear microphonic and the summating potential. The use of cochlear microphonic is particularly useful in assessing inner ear disease and also auditory neuropathy spectrum disorder, because in the patient with the auditory neuropathy, that is will certainly be absent ABR, but the cochlear microphonic will be present. So this kind of generates a bit of research into this. To be able to characterize the hearing status along the peripheral auditory pathway that was discussed previously, we use the audiogram. Why do we need to know about the audiogram? Because different types of hearing loss can have impact on ABR recording, and I will demonstrate this later. Now, the audiogram defines the presence types and the configuration of the hearing loss, if there's any. The aim of this is to find the minimal level hearing across the different pitch. On the audiogram, the y-axis is the sound intensity, and the x-axis is the pitch in hertz. It generally comprises the air and bone conduction audiometry. For the normal hearing, both air and bone conduction thresholds are within normal limits. Whereas the sensory neural hearing loss, which resulting from abnormal functioning of the cochlea, auditory nerve, or higher aspects of the central auditory perception or processing, both air and bone conduction thresholds have decreased. This can be demonstrated on the red line with a circle. That is the right hearing for the right ear. In fact, this patient has the right-sided acoustic neuroma. Another type of hearing loss is called conductive hearing loss, which results from the problem conducting sound wave anywhere along the route through the outer ear to the middle ear. So in order to diagnose the conductive hearing loss, both air and bone conduction threshold need to have a difference for at least 10 dB. In this audiogram, the right ear with the circle with the red line demonstrates the conductive hearing loss. So when both conductive and sensory neural hearing loss are present in the same ear, and then we define that loss as a mixed hearing loss. So this can be demonstrated with the blue line and the cross. The audiogram is often accompanied by a speech audiometry. That is the use of speech signals to assess a person's ability to hear speech, discriminate between words, and recall words. This classification system from the AOSIN combines the hearing threshold and the speech discrimination score that provides a quick guide to clinician about how good the individual's hearing is. Class A being normal, Class B being some hearing loss, but with very good ability to discriminate the word. And Class C and D are considered major deficits in hearing. So by doing the audiological assessment, we will know information about the auditory pathway. And if we are doing the BAEP, we can kind of expect the quality of this and to determine the appropriate stimulus to use. In order to understand the hearing loss and the impact on ABR, we need to have the normative latency values in milliseconds plotted against the stimulus intensity in dB/NHL. This is known as the latency intensity function, or you can say that input-output function. The graph in the middle shows the latency intensity function. The hatched area represents the mean latency with plus and minus 2 standard deviation. The figure on the right demonstrates waves 1 and 3 and 5 as well as interpeak latencies. In conductive hearing loss, the wave 1 of ABR is usually prolonged, and this also causes a latency shift for all ABR waves. This can be demonstrated on the latency intensity function. In saying that, there will be absent cochlear microphonic in conductive hearing loss. However, the interpeak latencies remain normal. With the cochlear loss, auditory thresholds at or above 50 dB/HL, waveform latency value and the waveform morphology may be affected. And according to the latency intensity function, there will be a slight prolongation for all ABR waves. Notably, that a severe and profound loss, there will possibly be no ABR waveforms. So this demonstrates on how the mixed loss can have impacts on ABR. And the audiogram shows the class A hearing for the right side, but a bit of a sensory neural component towards the high frequency, and the left side demonstrated class B hearing, but has the mixed hearing loss. So here's the ABR on the left, which demonstrates the mixed hearing loss, and the right side with the red color demonstrates the sensory neural hearing loss. Now, if you put on to the real fraction and condensation stimulus, you will see that there's absence of cochlear microphonics and on the left, and the presence microphonics on the right. With the retrocochlear pathology, almost certain that the ABR will be abnormal, and this demonstrates the right-sided acoustic neuroma. The left side ABR seems to be normal, but you can see because of the size of the tumor, it's very hard to get the ABR on the right side. It's virtually eventually absent. So this study kind of summarized that majority of the retrocochlear lesion will have the abnormal ABR, and some, and depending on size, some cannot be recorded, and ABR may not be useful in terms of detecting very small tumor. So the clinically abnormal ABR can be defined as both absolute wave latency and interpeak latency greater than 2.5 or 3 SD. With the retrocochlear dysfunction, it can be absence of all waves, abnormal prolongation of interpeak latency between 1 and 3, 3 and 5, and 1 and 5, and abnormal reduced wave 5 and 1 amplitude ratio, and as well as a significant interoral difference, which is greater than 0.3 milliseconds. Other factors need to be taken into consideration that includes the age. In newborn and infants, latency of ABR waves decreased from the birth of infants. This is probably due to incomplete nerve fiber myelination and immature synaptic functioning In adults, there's a very little variable amplitude and wave latency. In elderly, there's a slight increase in wave latency and a bit of a reduction in amplitude. This is probably due to delayed synaptic transmission associated with that age-related loss of neurons and changes in neural membrane permeability that might contribute to this effect. Gender-wise, females tend to have a shorter latency and larger amplitude compared to male. Temperature-wise, the reduced temperature tends to have increased latency. This is most likely due to the delayed synaptic transmission and also decreased axon conduction velocity. I believe that Dr. Hastings has given a very good overview on the anesthesia consideration for neuromonitoring earlier. But it's just that although in general that's the anesthesia agent should not have any impact on subcortical response, but it does have some response from the volatile, such as sevoflurane. So this study points out, although both waves 1 and 3 are normal, but you can see there's quite a bit of significant difference at wave 5. This table just demonstrates and shows there are 3 general principles of auditory evoked response measurements. For the stimulus, one needs to ask how adequate is the stimulus that they've used, and has the optimal stimulus repetition rate being used. For the filter, has the filter eliminates any unwanted electrical activity with the preservation of desired response. For the averaging, the extent of the signal averaging time needed to record a detectable response depends on the size of the signal and the amount of noise within the recording time frame. In terms of selecting the transducer to deliver the auditory stimulus, the insert headset is much preferred over the TDH39 headset, as the TDH39 headset tend to produce an electromagnetic field that may result in stimulus artifact in high intensity. One of the advantage of the insert is that the acoustic signal can be directed through a tube to a foam plug that is inserted into the outer portion of the ear canal, in which this can avoid any collapse of ear canal, and it has somehow better frequency response and less acoustic ringing. The figure on the right demonstrates that the advantages of the ERA3A insert headset over the TDH39 and 49 headset. In terms of the choice of the stimulus, the click stimulus is generally preferred. Now, because the click has abrupt onset and the broad spectrum, which can result in synchronous excitation of a broad population of neurons. The click in general is quite effective and can provide high-frequency information. So in other words, the abrupt click stimulus promotes the greatest amount of neural activity within the lower brainstem. This increase in neural activity provides the most robust waveforms with the best morphology. There are 3 types of commonly used clicks, and they are condensation, rarefaction, and alternating clicks. Rarefaction clicks and produce response of a shorter latency and greater amplitude than those generated by the condensation clicks. Whereas the condensation clicks seem to give the better response in terms of definition of the wave 5. However, the alternating clicks are most preferred because the stimulus-related electromagnetic artifact can be reduced, and the cochlear microphonic associated with each polarity is effectively cancelled out during averaging. So hence wave 1 of ABI is more easily identified. These slides demonstrate the impact of different stimulus rates to the ABI waveform morphology. You can see faster rate prolongs the latency of all waves. Higher stimulus rates also decrease the amplitude of waves prior to wave 5. Wave 2 and 4 are affected the most, followed by waves 1 and 3. Low rates are advisable when the full complement of wave is necessary, such as in the case of otoneurologic evaluations. So the goal of applying filter is to enhance signal detection, which comprise high and low pass filter. We need to avoid 60 Hz notch filter, as this is the common line frequency used in electricity. The recording sites are with the ipsilateral ear as active sites and vertex or frontal FZ as reference points. Typically, ipsi and contralateral responses are recorded. When interpreting the results, it generally needs to compare to the baseline response to see whether there's any change or not. Increase in 3 and 5 interpeak latency indicates the change in function of the structure of the ascending auditory pathway that located rostral to the generators of the wave 3, which is cochlear nucleus. Increased 1 to 3 interpeak latency often indicates changes in auditory function. And decrease of wave 3 amplitudes may also indicate post-operative deafness. We need also to be aware of the how repeatable the wave is. And sudden loss of waves is quite often associated with the vascular injury. For the warning criteria, in general, across any evoked potential monitoring, is that the 50% decrease in amplitude and the 10% increase in latency. For the ABR specifically, the prolongation of the wave 5 generate about 1 millisecond in latency increase is the concern, as well as the total disappearance of the wave 5. The increase of interpeak latency between 1 and 5, as well as the 1 and 3, are also needed to be taken into consideration. Ever since the introduction of BAEP monitoring, it has now been widely used in brain tumor surgery in CPA and posterior fossa, vestibular nerve section, microvascular decompression, and posterior fossa vascular abnormalities. So we'll be looking into some intraoperative BAEP. For this one, which was published by Liggett, they reported the sudden loss of the ABR when dissection took place at internal auditory canal. So acute loss of waves pretty much suggestive of the vascular injury. One of the limitations for ABR is that ABR is a far-field response, so therefore it may not be fast enough to detect changes in crucial stage. So the techniques have been developed to assist the auditory nerve in a rapid way. Moller and colleagues have developed a technique that gives more rapid response from the cochlear nerve by recording cochlear nerve action potential. This is done by placing the electrode, which is made from Teflon insulated silver wire, typically placed on the exposed 8th cranial nerve, showing the picture in the middle. So the cochlear nerve action potential is a triphasic form, and it has a different waveform morphology if it's recorded at the different location. Figure A demonstrated a normal auditory nerve compound action potential, which has a triphasic waveform. And in Figure B, after the electrocoagulation, we saw the loss of the triphasic waveform and to the second peak, in particular to almost biphasic waveform. These actually correlated well of changes in ABR shown on the right. So here's another way to record a cochlear nerve action potential by placing a clamp on cochlear nerve. It appears that the use of multimodal monitoring for cochlear nerve gives a better post-operative outcome in hearing preservation. This study showed the post-operative hearing matched population with only ABR and ABR with the cochlear nerve action potential. Post-operative hearing threshold with ABR alone is 82.5 dB, whereas the combination of ABR and cochlear nerve action potential is 54.1 dB. For the BAEPs in MVDs, we often see the transient change or transient loss or the complete loss, but we are trying to avoid the complete loss of the BAEP during the surgery. Although we know monitoring intraoperative BAEP reduces post-operative eighth nerve mobility and remains the most effective method to prevent hearing loss during MVD. But how accurate is BAEP during MVD? This meta-analysis has analyzed a series of studies on MVD with BAEP monitored. In terms of BAEP changes in this cohort of 2,540 subjects, approximately 1.8% of people with no change of BAEP experienced the hearing loss. Roughly 8.9% with significant change report hearing loss, and 35% with loss of BAEP reported the hearing loss. So after the thorough analysis of the data, the authors conclude that the intraoperative BAEP changes are highly specific in predicting hearing loss. The loss of response has high specificity in evaluating hearing loss. And it appears to that the sensitivity is a bit low. This is due to the therapeutic surgical pause in the MVD in response to changes of BAEP. The loss of BAEP during the procedure can be a specific biomarker of perioperative hearing loss. The patient undergoing MVD should have BAEP monitoring throughout to prevent hearing loss. In summary, understanding the anatomy and physiology of entire auditory pathway is important for ABR interpretation. Intraoperative usage of the BAEP provides surgeon with valuable information for integrity of the auditory nerve. It seems that the multimodal intraoperative BAEP in hearing preservation surgery will give better outcome. And the surgeon to perform complex procedure will certainly have more assurance. Thank you very much for your time and attention.
That's brilliant. Thank you very much, John, for that very comprehensive lecture and fantastic coverage of the theory and the application of auditory brainstem responses. So we have one question to start off with from the audience, and that is that the operating room is basically an environment in which it's very difficult to obtain signals. It's a very hostile environment, and sometimes the interference that we experience in the operating room is so significant that it stops you from getting reliable bear monitoring. And what sort of techniques and suggestions do you have for dealing with this situation?
Well, thank you very much for that question. That is actually a very good question. Now, in terms of resolving all those interferences, we could, first of all, reduce any electrical artifacts, for example, switch off the table if it's safely to do so. And so with the, and also we need to make sure that there's enough stimulus being delivered either peripherally or if it's auditory, just make sure that there's enough stimulus going through. And in terms of placing the electrodes, I found that if you kind of brings the length, shorten the distance between each leads, for example, twist it around, that will often resolve and also reduce some of the artifact there. And also, like I said in the lecture, try to avoid any the 60 hertz notch field, because that's where the electricity and frequency is, and also the number that will divide the 60, because that will also affect the waveform morphology.
Sure. What's your biggest tip, John, in your experience with doing brainstem auditory evoked potentials? What's your biggest tip for getting really good signals? What's your go-to thing that you really change if you're struggling?
Well, first of all, you need to check the repeatability of the waveform, because if you can repeat the waveform, which is pretty much nothing, and then you have to check others like the blood pressure or any confounding factor that might affect the waveform recording. And if that's the trend is real, and it's real, and then you have to report to the surgeon as well as the anesthetist. Yeah.
And how do you address the fact that you can have a completely normal auditory evoked potential recording intraoperatively, have a completely normal signal at the end of the procedure, and still have a 1% or 1 to 2% hearing loss in that population? On the other hand, you can have a complete loss of signal and you think, oh no, this is really terrible. This patient's going to have significant hearing impairment, and they work up hearing perfectly fine. How do you address that with your surgeons who might become a little bit skeptical on those experiences?
Yeah, I mean, this we do experience this from time to time. So I think it is important to get the pre and post-op assessment, like audio and ABR done, and so that way we can address this issue. But I mean, other than that, it could be due to other factors, such as the disruption of the blood supply around the region or something like that.
Great. All right. Well, thank you very much for that lecture, John. We greatly appreciate it. Sorry, I have one last question that's just come in. I have patients with normal hearing thresholds, but no bare responses on the side of the tumor. How can that be?
It also this can be a lot of things. Can be the auditory neuropathy or something, but really might requires a subsequent investigations like the MRI or something to see what exactly is going on there. I really can't tell. Really can't, because that's, like I said, it's it can be anything really.
And there's certainly confusion with bilateral hearing function and being able to localize that unilaterally. I've certainly seen patients in my experience who have clinically good hearing, and you try and get the brainstem responses and everything's just so dysynchronized in terms of their conduction pathways that you can't actually get good responses for that patient on that particular side. So certainly seen that a few times.
Yeah.
Brilliant, John. Thank you so much for your lecture and all the wonderful insights that you've given to us. And this being the lunchtime session, we actually let you go ahead and enjoy your lunch. So this is the end of the session thus far, and we will resume with the afternoon session at 1 p.m. Taiwan time, which is in 19 minutes from now. So I hope you enjoy your break. And once again, thank you very much, John, for that wonderful lecture.
Always a pleasure. Thank you very much. Thank you.